Hey guys, welcome back. This is Troy with the Advanced Spine Joint Wellness Center here in Medina. And this is our podcast. You can find us on iTunes by searching for Body Talk. And if you've heard the podcast before and you're happy with it, please go on over to iTunes, and leave a comment. Huge help for us there. And today I'm alone. There's no Dr. Corey, no Dr. Lily, no Dr. Matt today. So today I'm going to kind of pick up and we're going to start to build on what we've been talking about the past few weeks. And if you'd followed or listened to us the past few weeks, we talked a lot about gut health. What is gut health? How does that impact our health? What does that mean? How do we correct it? These kind of things. So if you watched us over the past few weeks, that's what we have been talking about. Now, today we're going to talk about diabetes, because one of the results of poor gut health, if it's gone unchecked for years and years and years, is diabetes. And what I'm going to do today is I'm going to break down what's called the pathophysiology for what diabetes is, meaning how does it occur? What happens? Why does diabetes occur? And then how do the complications of diabetes occur? Because we're going to talk about these complications next week. And the biggest one we're going to talk about is neuropathy. So stay tuned and we'll talk a little bit about diabetes. Now, to get us started, if you want to find us directly, you can go to the web and you can look for us on our website, ohiopain.com. And you can also contact us directly, 330-242-7669. So let's get started with diabetes. Diabetes is a metabolic disorder, which just means that it's a type of problem that affects our ability to put something into our body, use it, and then eliminate the waste. And diabetes is affecting, at this point, 80% of our population. And the potential risks of diabetes and the complications of diabetes are growing significantly. So diabetes, to start with, what is it? So diabetes is the inability to basically metabolize sugar and then burn sugar. Now, sugar is kind of a term that's a misnomer. Many people think that diabetes, when you talk about sugar, is just talking about sweets. I don't eat sweets. Ho-Hos and Twinkies and Zingers and Halloween candy, these kind of things. But many patients don't realize that many of the things that you're eating daily are converted straight to sugar. That can be things like dairy. Dairy is converted straight to sugar. Some of these grains, breads, the crackers that we eat, yogurt. Many people think that yogurt is great. Some oatmeal's converted straight to sugar. So sugar is kind of a broad-based term. Many patients think that they're eating things that are good, and you're not. And these things are converted over to sugar. So basically the body starts to get bombarded with sugar. And I want you to think of a cell as kind of like a room with a door. And there's only one door to get into that room. And what happens is the cell needs sugar. It needs it for energy. We need it for our metabolisms. Our brain needs glucose. It runs 80% on sugar or glucose. But what happens is we get all this sugar. And again, imagine this room and we have one door. And you throw a hose in that room and the room just starts filling up with water. Once it's full of water, it can't take anymore. And that's what happens with diabetes, is we start to flood all of these little rooms or these cells, not with water, but with sugar. And then what happens is we start to see some resistance to it. Insulin, which we know is part of diabetes, insulin is what opens up the door to the room to allow the sugar to get in. But our cells are so full of sugar, they become what's called insulin resistant. And what that means is insulin comes and it's the key to opening the door, but the door won't work anymore because it's so full of sugar that it won't let any more in the room and it starts to pile up in our bloodstream. So that's essentially what diabetes is. We're trying to get sugar into these cells, but we can't because they're full. And what normally used to open the door to the rooms that's locked won't open it anymore. So now the sugar begins to start pulling into the bloodstream. And that's essentially what diabetes is. Now, many people don't know that they're developing prediabetes, and this is a huge, huge fault of our healthcare system, is that many patients are walking around with early insulin resistance, meaning that the rooms are starting to get full, and we can test that and see that with the hemoglobin A1C, and we can find that patients are in what's called prediabetes, but nobody does anything about it. We just kind of go, oh, we need to watch that. This is oftentimes what happens when we see patients here, is they come and go, well, the doctors told me I was pre-diabetic years ago, but now I'm diabetic. Well, of course you are, because we didn't do anything for it. So there are tests that can be done looking for some of the early stages of diabetes, called prediabetes. And when we catch early insulin resistance early on, we can actually change it very rapidly within 2 to 3 months with nutritional coaching and counseling. But oftentimes it goes overlooked, and then we develop full-blown diabetes. So once we're into diabetes, some of these early symptoms that develop, even in prediabetes, is we'll start to see that you may become a bit more thirsty than you were previously. We call it polydipsia. So polydipsia is a very common early symptom of diabetes where we want to drink more water. So you feel thirsty. The second one is called polyuria. So we begin to urinate more often. So we're running to the bathroom more often. So we're running more water, we're running to the bathroom more often. And then the third one is polyphagia. These are the most common 3 symptoms. And polyphagia means that we're getting hungry more often. So the early 3 symptoms of diabetes that oftentimes go undetected that we can recognize and go, maybe there's a problem, are what doctors call the 3 Ps: polyuria, polydipsia, polyphagia, meaning we want to eat more than we used to, we're hungry. We want to drink more than we used to, we're thirsty, and now we're running to the bathroom more, we're peeing more often. So the 3 Ps, again, those are the 3 earliest symptoms of diabetes or prediabetes. And most doctors don't counsel patients on this. So if you're out there and you go, gosh, I'm thirsty more often, I'm gaining weight, I'm starting to see that I'm hungry more often, I've got a family history of diabetes, this might be something you want to look into. And if you do some blood tests and you have some early insulin resistance, again, very, very easy to catch. Now, these are some of the early symptoms, but there's others that can be involved too. And some of the other symptoms that we see actually develop a lot in prediabetes are what are called neuropathies. Now, I'm not going to go into too much detail about this next week or this week, because this is really our point to talk about next week. And this is a big, big side effect of diabetes, and not just diabetes, but it's a huge problem in our country is these neuropathies, which means numbness or tingling or burning in the hands or feet. It's one of the other early symptoms. We can also see high blood pressure kind of start to creep in. Maybe some kidney disease, some early kidney disease begins to creep in. And these are the early symptoms that we see with diabetes, but it's another one of these quiet ones. And these symptoms are very mild, and many patients don't recognize them, much like high blood pressure. And they call high blood pressure the silent killer because you don't feel anything until you really develop a big problem like a heart attack or a stroke. Diabetes is one of those. It silently creeps up until it becomes a big issue. Now let's talk a little bit about this blood sugar. So this sugar molecule, now we have a lot of this sugar molecule kind of floating around the bloodstream, and our body doesn't know what to do with it. So we can detect excess blood sugar by doing a urine test. That's where a lot of patients will start to see that diabetes gets picked up as they're going in for a routine physical, and maybe they pee in the cup, and we do a glucose test and we see that it's high, then they start doing blood tests and find that there's a problem. So one thing that happens is we start to try to urinate the excess sugar out. And by urinating this excess sugar out, it is a bit of a diuretic. And in some patients, this can lead to a tremendous complication and other complications where you're losing too much water, losing potassium, which can then start to cause heart troubles, and it starts leading to a myriad of other problems. But the sugar molecule itself, as it's floating around, it's a very large molecule. And if you look at the other things that are floating around in our bloodstream, red blood cells, things like this, they're small. And they're designed to be small so they can go through the very, very minute, small blood vessels in our hands, in our feet, in our eyes, in the kidneys. There's these wee tiny little blood vessels. I like to describe them as kind of like the roots on a tree. If you look at a huge oak tree and you look at the initial roots that you can see, they're very large. But then as the roots go deeper, 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 get further away from the larger roots in the tree, they get small. And some of them are so small, they're almost like a hair on our head. They're wee tiny. And that's the way these blood vessels are. As the further they get away from our heart into our arms, legs, feet, toes, and fingers, they're very small. But this sugar molecule that's floating around is extremely large. And it becomes a problem in these small blood vessels because it actually starts to clog it up. And here is where we start to see some of our major complications of diabetes, which we'll talk about over the next few weeks. But these sugar molecules will start to clog up in these capillaries, and they start to actually attach to these small capillaries. And I'm going to use a medical word here. I don't like to use big words sometimes when we're doing these podcasts, but it's called glycosylation. And what happens is this blood sugar begins to attach to these small capillaries and blood vessels. Our body recognizes that as abnormal and goes, why are these molecules attached to these capillaries? And they become damaged. Our immune system actually attacks these capillaries, and we no longer have them. So diabetics will develop poor circulation for this reason. We're losing our microcirculation. Now, this is really important, and this is an extremely important point when it comes to our overall health and the complications of diabetes. And where we're going to lose our microcirculation is where these small blood vessels are actually in areas the most. And these are, again, in our eyes, the retina, in our kidneys, and in our hands and feet. So every diabetic, there's not a single one that's going to escape the complication of neuropathies, kidney issues, and macular degeneration or vision problems. They all go blind at some point too, or have vision problems, because these small little blood vessels in these areas are being damaged, and essentially we're losing that circulation to that area. The problem is that in these areas, this microcirculation, it brings blood and nutrients to the smallest of our nerves, which are also the little tiny hairs, just like that tree trunk. We have these small tiny blood vessels. We also have these small tiny nerves, and these small tiny blood vessels feed these nerves. But if we lose that circulation, that microcirculation to these small nerves, this is where we then see the complications begin. And again, our complications, our number one group of complications, the peripheral neuropathy, so neuropathy in the hands and feet, the vision, macular degeneration, glaucoma, things like this. So we start to see damage in the eyes, and then the kidney disease, because we're now no longer getting microcirculation to the very small nerves. And if we don't give circulation to our heart, if we lose blood flow to the heart, one big artery in the heart, if we clog it up, we feel it. We have a heart attack, and symptoms develop from a heart attack. We start to lose circulation to our hands and feet, to these nerves, we feel it. And that's where you're going to get the complications of neuropathy with numbness, tingling, burning, these kind of things. So that's kind of the pathophysiology of diabetes and what begins to cause this problem. Now, our traditional American system, are we good at treating it? Nope. We are terrible at it. And the reason I say that is the doctors are very good at giving you medicines. And if you're out there and you're listening to this and you're diabetic, the doctors are great at giving you medicines, but every single diabetic still is dealing with high blood sugar every day. And every diabetic still has an elevated A1C. And the reason being is if we never fix nutrition, you'll never cure diabetes. And it always drives me crazy when I'm meeting with a new patient here in our clinic, and I'm going through a health history, and I go, oh, I see you're on some diabetes medicines. And they go, yeah, but I don't have that. I take a medicine for it. Well, yes, you do. And if you think that just taking a medicine for it actually fixes the problem, it doesn't. And you will develop the complications of diabetes, and sometimes even lead to big problems down the road, like foot amputations, things like this. And I'm sure many of you guys, if you're diabetic or know friends that are diabetic, have seen this complication occur. And the medicines are only seeking to push the blood sugar down. They're only trying to manage the blood sugar in one way or another, whether it's insulin, glucophage, some of these new ones, Trulicity, things like this. They are not curing your diabetes. So the only way to actually cure or reverse diabetes is with nutrition. And it's a lot of tricks with nutrition. And again, we see so many diabetics who are working really hard on nutrition. I just met with one yesterday, and she's what doctors label a brittle diabetic. So no matter what they do with medicines, the diabetes just doesn't respond. And I met this young lady in our anti-aging clinic. She's only 43 years old. She's not overweight, but she cannot control her blood sugar. So they've put her on 7 or 8 different medicines, sliding scales of insulin, Humalog insulin, long-acting insulin, a handful of different medicines, and she's still having problems. So my job here isn't to add more medicines. My job is to figure out what was she eating. So I did a nutrition log with this young lady, and she's like, no, I eat good, I eat good. There's no problems with my nutrition. So I was like, just humor me, just humor me and do this nutrition log for 7 days. Let's see what's going on. And this young lady was eating nothing but sugar. So in the morning for breakfast, it was yogurt. And if you look at yogurt, yogurt is dairy. And then what is in yogurt? Lots of sugar. So that fruit that is in there has loads of sugar in it. It's 43 grams of sugar that was in her yogurt. That's like drinking a can of pop. So there was sugar number one. Number two thing she was doing for breakfast was oatmeal. So now we have two things of sugar for breakfast. So we've got sugar and sugar. So then I was looking at her snacks. I said, okay, what's next here? So that was breakfast. We had sugar and sugar. There was orange juice in there too. So sugar number three. Now the thing she was doing for lunch, which she thought was good, was partially good. She would either do celery or an apple, which is good, but she would lather it up with half a jar of peanut butter. Now, she thought peanut butter was good because it's a protein, but it's not, because there's tons of sugar in traditional peanut butter. So that was loaded with sugar. Then we got to lunch and so on and so on. For lunch, she had whole grain bread, but whole grain bread, guess what that converts to? If you don't know it, sugar. So that threw out lunch, and then we got to dinner and we were looking at mashed potatoes, which are converted to sugar. So it was just one thing after another that she thought was correct based on the traditional guidelines that we see with the FDA and some of the other regulatory agencies here who tell us, what we should be eating. And everything she was doing was incorrect. And all 7 days were basically essentially very similar. There were graham crackers on another day where she thought those were okay. Nope. So there's so many things out there that many patients are doing that they think are okay. So the only way you can actually reverse this, if you've caught it early on, you're in early insulin resistance, maybe your doctor's told you that you have an elevated A1C. The number one thing you can start doing right now is start working on learning about true nutrition. If you're confused on that, you can reach out to us. You can comment on the podcast here. If you're live on Facebook, you can comment there. You can email us directly through our website if you have questions. If you want a consultation, you can come into our office. Again, you can find us at ohiopain.com. But that's really the pathophysiology of diabetes. How does it occur? What's going on in this microcirculation that's leading to our complications? The current treatment for most patients is just medicines with very little guidance on nutrition, and your fix is nutrition. Now, without nutrition, again, every diabetic still has elevated blood sugars. Most are still running 110 to 140 on the low end. That's a good day for most diabetics. And if you're running at 110 or 140, guess what? You're still going to develop complications. And if you're wondering why those are occurring, it's because the diabetes still is not managed. The blood sugar is designed to be below 100 consistently, and our hemoglobin A1C should be below 5.6. That's normal. Now I get it, like a lot of diabetics, you have to work hard to even get your A1C down into 6 or 7. But even with an A1C at 6 or 7, there's still a guarantee. And again, you're going to develop complications. At some point, it will occur. So next week, we'll talk about neuropathy. We're going to talk about the pathophysiology of neuropathy. Why does this occur? What is it? What does that mean? Who most commonly gets it? And it doesn't always just impact diabetics. So even if you're not diabetic and you have neuropathy, this will apply, because even though diabetes is the number one cause of a neuropathy, there are about 20 other potential causes of neuropathies, from chemotherapy to heavy metal and toxic exposure, mineral deficiencies, liver or kidney disease, infectious diseases. So there's lots of other things that can cause neuropathies too, pinched nerves in the back. So if you have neuropathy, or if you've heard of neuropathies, we will talk about that next week. Again, if you like our podcast, you can look on iTunes, you can find us at Body Talk. And again, if you like the podcast, please like or share this. And if you're on Facebook Live, if you have questions or concerns, click on the link, you can comment. We'll reply usually within 5 to 30 minutes. And if you want to find us directly here in Medina, Ohio, you can look on the web. You can go to ohiopain.com, or you can contact us directly, 330-242-7669. Until next time.